This week on the BackTable podcast.
The future of medicine is a team sport. We get the best outcomes for patients when we cooperate with each other. We have a phenomenal group of radiologists. Working with each of these radiologists has made my practice better. It has made things easier. It has made just even, outside of just the ablation, we know each other and get along and can get things done for patients in a faster way. So I would encourage urologists to reach out to the radiology colleagues, work with them closely. I think if nothing better than for better patient outcomes, but you can also build a successful program and you can do more surgery on the right people who need and who will benefit from surgery if you also offer other things like ablation and surveillance, of course, for small renal tumors.
My name is Ruchika Talwar, and I'm a urologic oncologist at Vanderbilt University in Nashville, Tennessee. Today, I'm really excited about the episode that we have lined up. We'll be chatting about multidisciplinary approaches to treating renal tumors, and I'm joined by urologist Dr. Jason Abel and radiologist Dr. Lewis Hinshaw from the University of Wisconsin. Thanks so much to both of you for spending some time to share your wisdom with us.
Thank you. Looking forward to it.
It's a pleasure to be on your podcast. Thanks for having me.
Awesome. Well, let's dive right in. Lewis, why don't we start off? Tell me a bit about yourself and your specific area of expertise.
So my name is Lewis Hinshaw, and I am the section chief of abdominal imaging and intervention here at the University of Wisconsin. And although I do a wide variety of clinical work in both diagnostic and intervention, most of my research and a lot of my interventional clinical work has been in image-guided procedures, and specifically in image-guided ablation, utilizing multiple different ablation tools in multiple different organs, although certainly what we're here to talk about today is the management of renal tumors in our program here at University of Wisconsin, working with our urology colleagues.
Great. Jason, what about you?
Yeah, my name is Jason Abel. I'm a professor of urology and radiology at the University of Wisconsin. I'm the chief of urologic oncology, and my research and clinical focus for the last 15 years has been on the treatment of kidney tumors.
And, a little bit of background here. I'm curious if you would be willing to share the history on how your two departments started, working more closely for the care of patients with renal tumors.
I can take that one since I've been here a little bit longer than Jason. So back about 20 years ago, actually, more than 20 years ago now, Dr. Fred Lee and Dr. Steve Nakata were working here. Well, they still are. They're still our partners. And they were developing both the technology for image-guided ablation as well as the clinical program. And it quickly became apparent that the talents of both groups, both urology and radiology, would be helpful to developing this program, not only on the clinical side, but on the research side. And so they developed a collaborative program that utilizes both urology and the radiology teams to do both clinical work and research. And that program has just developed and thrived over the years with a lot of both clinical growth and incredible research program that has done a lot of groundbreaking research over the years to kind of explore the possibilities with image-guided ablation and what we can achieve.
Hearing about the background of the collaboration, how sort of did you get involved in partnering with Lewis? What kinds of patients are you sharing, and what's the kind of synergy in how you figure out who's a candidate for potentially an image-guided procedure?
Thanks. I think urologists and radiologists really have a natural synergy. At most programs, urologists work closely with radiologists to get things like percutaneous access or other procedures. So we're very familiar with our radiology colleagues. But the synergy is even more for renal tumors. When I was in medical school, the thing was renal cell cancer, we always called it the internist tumor, because patients would present with things like paraneoplastic syndromes. But I think a lot of that has really changed. And you could make a strong argument that in 2025, small renal masses especially are more the radiologist tumor. We know there's an increased detection of kidney tumors because of advanced imaging, CT, MRI screening for other diseases, traumas. We identify a large number of kidney tumors, but the majority of these tumors are small tumors. At UW, we really have kind of developed a close working relationship with our radiologists especially with renal mass biopsy and different percutaneous ablation techniques.
Yeah, I think that's right. And I think as time goes on, as we find these smaller tumors, I know even myself in my conversations with my patients, the question always is, well, we found it. What do we do now? Because I'm not sure that, had we not found it, this ever would have caused a problem for you. We really are in an interesting era, and we find ourselves in these conundrums of not jumping too quickly to overly aggressively address some of these renal tumors. So I think you're right. I think especially as time goes on, having these sorts of collaborative approaches, it's a great way to ensure that patients getting appropriate care and that we're exploring the boundaries of how technology can help us avoid overtreatment in some cases. And, to that end, Louis, I'm curious if you would be willing to share a bit more detail about what options you're offering at this point. I know a lot of people may be familiar with cryoablation to treat these tumors, but from what I understand, you have some emerging new technologies within your group.
Sure, absolutely. I'm not sure if it can be called an emerging new technology anymore, but 95% of our tumors at this point are treated with microwave ablation. We started that program back in 2011 when the system came online in the US, and we've been using it pretty consistently ever since. Honestly, I was a little slow to change over to microwave because we had a really successful program with cryoablation for many years. And so, when you think about a program that's very successful with a low complication rate, great oncologic outcomes, it's really kind of challenging to envision transitioning to a different technology. So it took me a year or two to become fully convinced that this was the right thing to do. And I think that the data since then has kind of proven out that microwave has some significant advantages compared to cryoablation for the treatment of renal tumors. So most of our cases are done with microwave. But that being said, all cases are not appropriate for microwave. So we still have a percentage of our patients that are treated with cryoablation. And then we're in the very early phases of exploring histotripsy in the setting of renal tumors with some early clinical trials.
Awesome. Well, tell me a bit about who is appropriate for microwave ablation. You mentioned some cases you still utilize cryoablation. Let's get into some of those details.
Sure. Cryoablation, one of the big advantages of cryoablation is that it's very precise because you can easily and very precisely visualize the edge of the ice ball. And that edge of the ice ball, although it is not necessarily the cytotoxic margin, it gives you a good idea of where that cytotoxic margin will be. And so if you're close to a delicate structure that you do not want to injure and you want to be relatively precise, it can be helpful in that way. The second advantage of cryoablation is that it's relatively gentle on the collecting system. So if you're working in a location where you're concerned about injuring a significant component of the collecting system, such as the ureter, it can be advantageous because even if you do involve it in the ablation zone, you have the possibility that you won't have significant downstream clinical effects. Whereas with microwave, if you do injure the ureter or other significant components of the collecting system, you almost certainly have significant effects. That being said, there are ways to protect the ureter that we can talk about. But in general, when we're triaging these patients, we utilize cryo in patients that have very central tumors that are close to the ureter or other very, kind of central components of the collecting system. Most other patients are triaged to microwave at this point.
And tell me a bit about the role of hydrodissection. How can that potentially increase the pool of patients who are candidates for microwave ablation?
Yeah, so hydrodissection is a tool that was developed probably about 12 to 15 years ago now as a commonly utilized tool in the setting of ablation. And we use it in all organs and all systems. And it's essentially a method for displacing and thermally protecting adjacent vulnerable structures. In the case of the kidney, it's most frequently used to displace bowel, but it can also be used to displace the pancreas or the adrenal gland. In the setting of liver, we also use it as well quite a bit, as well as other locations. But in the setting of kidney, what it did was it essentially eliminated the need to go to the operating room to displace those structures and allowed us to treat most of these small renal tumors utilizing a percutaneous technique, much less invasive and much quicker recovery. And so it allows us to treat pretty much nowadays, adjacent structures are not a contraindication for percutaneous ablation, whereas early in our experience, it certainly was.
Got it. Jason, I'm curious to hear your perspective, switching gears a little bit away from some of those technical considerations. You know, Often you're the one initially seeing the patient. We find a kidney tumor, patient is referred to a urologist. You're sort of that first stop in talking to them about this finding, potential options, et cetera. Can you share a bit more on your clinical decision making? We can talk a bit about workup, but also who, in your opinion, would be a better candidate for microablation or other ablative techniques versus who may be a better candidate for surgery?
Yeah, no, I think that as we mentioned earlier, we're seeing more and more patients. We're identifying patients with small renal masses, and we're not exactly sure what to do with some of these patients as far as what the best treatment is for them. I think first and foremost, we have to recognize we did a small study in 100 consecutive patients a few years ago where we gave them a survey prior to visiting with the urologist, and they just ranked their anxiety on a visual Likert scale. And one of the things that was really informative about this was a huge amount of patients ranked this clinic visit as one of the most stressful times in their life. And
Wow.
so I learned really two things from this, right? That a level of anxiety was not proportional to the risk that we knew it, because we know that the risk from a small renal mass is very small. But second, it's different than when the mass is inside you, right? And so one of the first things I do when I talk to a patient that comes in with a small renal mass is try to de-escalate things a little bit so that we can make better decisions. So, one of the good pieces of data is if you look at the DISARM registry and where they followed some patients and some patients were treated immediately, you look at 5 years, the cause-specific survival was over 99% in both arms. So realizing that this isn't something that's going to happen very quickly for most patients really kind of sets the initial, expectations. And then trying to make a shared decision with them, but realizing that this is not an urgent decision. So it's really important for many patients to consider all the different options. And I think that tumor ablation is one of the options that we offer here at UW that I think has some distinct advantages. I don't think it's, the best option for every patient, but we try to discuss it with every patient because it is an option. And if you look at some of the, population-based studies from a few years ago, maybe 1 in every 7 patients was being treated with ablation, which is quite a bit. We don't know what the newer data show, but I'm guessing giving the favorable perioperative morbidity and renal functional outcomes and treatment success that it's going to be continue to get more common. So when we talk about patients, to answer your question, when we talk about it with patients who are a little bit more older or more comorbid are excellent ablation candidates. Patients who are younger or have a little bit larger tumors, we generally still continue to favor surgery. We just don't have studies in those groups, out 10, 15 years that have showed equivalent outcomes. But we still, in the studies we do have great outcomes. And I think that one of the reasons that the consensus guidelines have all mentioned ablation as a treatment option for kidney tumors is because we can see that the outcomes, things like metastasis-free survival or cause-specific survival are equivalent in the studies that we have. So we discuss it with patients and, we discuss the fact that a few years ago, we recognized that the mortality or the morbidity from decreasing a patient's renal function is really important. And that's why we less commonly use radical nephrectomy. So we try to do either observation, partial nephrectomy, or ablation for the vast majority of patients with small renal masses.
Yeah. And I'm curious, you mentioned size as a criteria. We're referring to small renal masses, which I think in general people refer to, under 3 centimeters. But do you have a specific size cutoff, or is it really a case by case basis?
We definitely think smaller tumors have better success among all modalities, but we will treat patients up to 4 centimeters. And then when it gets more than 4 centimeters, we talk to patients on an individual basis. We had looked at a study a few years ago when Dan Shapiro was a resident. He was the first author. And we just compared the surgical outcomes to patients who were treated with ablation over 4 centimeters. And these were all patients who had either refused surgery or were just very poor surgical candidates. The majority of those patients were on active surveillance and had grown at least 5 millimeters in the prior year. And we were kind of impressed to see that The 5-year, again, cause-specific survival, I think the level of local recurrence was about 5% in the microwave group compared to about 2% in the partial group and 1% in the radical group, but still very similar in a very comorbid population. So I think it's something we consider on a case-by-case basis, and we definitely think that microwave ablation, one of the big advantages is that you can get some synergy with the energy and treat larger tumors than you could with radiofrequency ablation.
Yeah, Lewis, curious to hear your thoughts from a technical perspective on masses that may be sort of, approaching the limit there regarding size.
Sure, yeah. So as Jason mentioned, with radiofrequency ablation, which is what the initial heat-based modality was with ablation, you had significant limitations on size of tumor that you could actually effectively treat. And for radiofrequency ablation, the results started to drop off somewhere between 2 and 3 centimeters. And above 4 centimeters was really actually probably not acceptable results. That's one of the reasons that actually we like to use cryoablation back prior to the advent of microwave, is that with cryoablation, you can utilize multiple cryoprobes and you can create actually fairly large ablation zones and effective ablation zones even to treat larger tumors. But then your complication rate would potentially go up with that as you created a larger ablation zone without cautery effect, and the resulting increase in bleeding was a concern. With microwave ablation, the kind of results across the board show that we're pretty consistent and effective up to 4 centimeters. After that, our results do start to fall off, but not as precipitously as they did with RF. And so as a result, as mentioned by Jason, we can treat tumors larger than 4 centimeters. And in our series of tumors between 4 and 7 centimeters, we actually had relatively equivalent local tumor control with a slightly higher complication rate in those patients. So it isn't necessarily a limit at 4 centimeters, but you do have to consider other options a little bit more strongly as you get above 4 centimeters.
Yeah.
On that note, I think it's important to realize too, those weren't maybe procedural related complications. Those were very, very sick patients that were having complications from the anesthesia, mostly with that.
Yeah, no, it's a great point. It's a great point. And I think, again, if you think about time under anesthesia, even if they do require some sort of anesthesia, it's certainly going to be less with an ablative technique in most cases than with, an attempted surgery. So I think that's a great call out that despite the fact that you're seeing complications, those may have actually been worse if you had gone straight to surgery. So I appreciate you bringing that up. Especially in these complicated cases, I mean, I certainly imagine there's some discussion there, there's nuance. So from a practical perspective, a lot of academic centers have things like tumor boards. Is that a place where you're able to discuss these cases? And do you have any suggestions for folks who are interested in adopting this approach who may not be in an academic setting?
We've always had kind of a weekly meeting where the urologists and the radiologists get together and talk about, early on it was a lot of research planning. Now we have such a busy practice. We're just running through the patients that, are potentials versus, the next week's schedule. So I think, formalizing and setting a planned meeting where you talk about, the feasibility and, which probes you're going to use, are you going to need hydrodissection? Does this patient have any specific concerns that we're related to? I think it really helps to build a team, but then also to give the patients the best care.
Absolutely. Lewis, any thoughts?
Yeah, absolutely. As Jason mentioned, we have a weekly meeting. Even before that, even before we formalized it, we often met and talked about patients. But I think formalizing it and creating a weekly time for us to get together and actually, in a very kind of specific way, go through the patients and discuss these different issues, not only does it create a better kind of collaboration between the teams, but it also educates both sides about what the urologist is thinking when they're looking in the case and what we're thinking when we look at a case. And that really helps inform decision-making as we go through these patients and discuss, what might be better for which patient and why. Otherwise, I mean, even though I, obviously went through urology as a medical student, I really have no real understanding of a lot of the decisions that they're making and the challenges that they encounter when they're in surgery, and vice versa. So it's really been helpful.
Yeah, we're all always learning. And I think that perspective is really important. Jason?
Yeah, I just want to make a point on that. One of the great parts about this team and this collaboration is we have really different but complementary skill sets. And I really learn a lot every time we interact with our radiology colleagues, just because, So when we look at a tumor, something that might be easy to treat surgically might not be as easy to treat from a radiologic perspective, and vice versa. And I think that we can get the best outcomes when we talk about that. I think that when I go to meetings, especially urology meetings, people will look at an anterior tumor or a tumor that's, against, the backside of the pancreas and say, oh, you can't ablate that. We do that routinely because of things like hydrodissection. You can move things far enough away to where it's not a dangerous procedure. But again, without seeing this, without our radiology colleagues, that wouldn't be possible.
Yeah, great point. I mean, I've certainly heard that argument before. And similarly, I think a lot of times people think, oh, small tumor, like just send for ablation, no need to put the patient under anesthesia. But perhaps there are times where surgery may actually be a lot more straightforward than ablation, I imagine. So those conversations, I'm sure, are really, really helpful. Along these lines, I'd like to get into a bit of the nitty-gritties about, this idea of potentially sharing the patient and sharing the treatment from a billing perspective. So, Jason, you're the one who's initially seeing the patient for consultation. I think there's, specifically on the urology side, perhaps sometimes this sense of, well, I don't want to lose this patient if I am to refer them for an ablative therapy. So I'm curious to hear your thoughts on sharing the patient in the treatment and, the billing considerations there.
I think that we have to back away from the idea of competition in medicine. And I think that we can work together as a team to get the best outcomes. And that's really how we approach things. There's some patients for which ablation is not the best treatment, and vice versa with surgery. I think that we know that it's definitely an easier recovery, versus surgery. There's definitely, faster recovery as far as you're in and out of the hospital, or sometimes you're not staying overnight, that you can get back to your normal business very quickly, with a very small tumor. I think that we have tried to be very collaborative in the fact that we have put the patient outcomes at the forefront rather than thinking about things. And I think we've decided very early on to split things down the middle. And I think that as our programs have grown, it has increased our surgical volume to be doing ablation and vice versa, because our brand is really more, what is the truth? What is the best treatment for that patient, rather than what's going to make what either department a more lucrative decision. And realistically, I mean, if you look during the same period that we've grown so much, our proportion of patients who are treated with active surveillance has grown the most. So we're seeing even more patients, and about half of our patients are put on active surveillance when we see them, because that we know that's the most appropriate thing these days.
Lewis, anything to add there?
Yeah, not really. I think you summarized it well. I think I've had this conversation many times with colleagues about other technologies that are available. And the reality is that sometimes when you're a hammer, everything looks like a nail, but that's not the most appropriate way to get the best patient outcomes. And I think we really, like Jason said, need to back away from this concept of competition and really embrace the kind of multidisciplinary approach of treating patients to get your best outcomes. And whatever tool or process that is best for that patient is what we should be choosing. And if I'm not able to provide that tool, I need to find one of my colleagues that is. And I think that's really the approach we've taken here. And I think it's helped our program thrive, develop a reputation that pulls in patients from outside this area. And that's really kind of been a great for both teams.
Yeah, I love that philosophy. I mean, I think certainly the patient is at the center of everything we do. And I love that you've been able to adopt that while still, it sounds like, promoting, maybe because of your strategy, significant growth. I do think out in, particularly in places where perhaps this sort of relationship is not as developed as it's been for you all, it's a concern. It's a concern. But I think if we remind ourselves that, the ultimate goal is to certainly ensure we're providing the best care, then inherently you'll see growth. So really love that experience that you all have had. Lois, we did talk about this a bit in terms of technique and the role of hydrodissection and all of that. But, tell me, I want to hear more about, like, from a patient experience, generally, is this a same-day procedure? Do you monitor some patients overnight? What are sort of complications that you counsel patients to be aware of, and a recovery period?
Sure. So most of our patients come in the morning of the day of the procedure. We do use general anesthesia for the majority of our patients, unless there is some kind of contraindication or reason not to put them under general anesthesia. And the reason is because it actually is easier on both the patient and on the team. It's better if you're not worrying about conscious sedation and if they're sedated enough, but rather focusing on the procedure that you're doing. So most of them go under general anesthesia. Patients with smaller tumors and lower comorbidities can go home the same day, but patients with larger tumors and more comorbidities, we almost always keep overnight in the hospital. They almost always go home in the morning. It's less than 1% of our patients that have a longer hospital stay. What I tell them from a recovery standpoint is I expect them to be a little sore and perhaps have a little bit of what we call post-ablation syndrome, which is a low-grade fever, achy, kind of flu-like syndrome that can happen in the days following the ablation, and that those symptoms respond very well to Tylenol and or ibuprofen. And after about 2 to 3 days of taking it easy and no heavy lifting, I ask them to work their way back up in normal activities with the expectation that a week after the procedure, they should be back at their normal functioning level without significant symptoms. And if they aren't, we ask them to get in touch with us. But that's kind of the expectation, is essentially a week of recovery. That being said, most people feel quite well within 3 or 4 days and ready to go back to activities. So it's a very fast recovery and usually uncomplicated. Of course, if they have complications like bleeding and things like that, then we may alter those recommendations slightly, but those are our typical recommendations and recovery timeline.
I imagine rates of complications such as bleeding are extremely low in line with other ablative techniques. But again, what would you say, you generally counsel patients about the specifics regarding that?
Yeah, so again, there's a little bit of a correlation with tumor size and the size of the tumor that you're treating. But in all cases, it's less than 2%. And in most patients, it's less than 1% of having a significant bleed that we would have to intervene on. Everybody bleeds some, of course, that's just part of putting needles into patients. But significant bleeding that we actually have to intervene on is actually quite rare.
Got it. And Jason, you're obviously probably seeing the patients for their surveillance imaging, or maybe not you specifically, but your team in general is going to be following those patients. So, are there any differences in how you surveil these patients or your ability to interpret post-ablation scans in the microwave ablation population versus other techniques?
I think that, again, this is where a team approach is great, because we can also talk with our radiology colleagues anytime there's any questions. For the most part, our patients are followed with a contrast-enhanced CT or MRI, and we're looking for an absence of enhancement, an absence of nodular enhancement specifically. And then we follow that over time. And for the vast majority of patients, you don't see anything. When you do see a recurrence, it's usually pretty obvious. I think it was seeing some patients who had been treated with cryo or RFA. I think it's similar. I think it's similar as far as what we see. You don't see things go away as much with microwave. I think that area has a lack of enhancement, and it is something that we can follow for years or decades on some of these patients now and see the lack of enhancement. I don't know if Lewis has any more technical terms from the MRI or the CT standpoint.
Yeah, sure. So there are some subtle differences, as Jason kind of got at there a little bit, which is that with cryoablation, for example, you have quite a bit of tissue contraction over time. So you often, 10 years down the road, you may not even be able to visualize the fact that there's a mass there. You may just see a cortical scar. But in the case of microwave, because you create such a dense, desiccated ablation zone, the tumor almost never really goes completely away. So you have a kind of a mass-like lesion there, but it is completely not enhancing. And that is where you're able to define whether or not there is recurrent or residual disease. And again, as Jason said, it's usually fairly obvious that you have recurrence or residual, because those recurrences almost always, they do always occur at the periphery of the tumor, where the heat is less intense, and you may have missed a cluster of cells. And that area, it usually becomes fairly obvious because it's a nodular area of abnormality and enhancement. The difference with cryo is sometimes you would have recurrent or residual disease that occurred within the ablation zone, which can be a little bit more challenging to appreciate. And so I think actually with microwave, it's a little bit easier to follow over time from an imaging standpoint than cryoablation sometimes, although both are relatively straightforward as far as identifying residual disease.
On that point, I just wanted to say from a urologist perspective, one of the advantages of microwave ablation that I saw early on and really kind of convinced me is the opinion that it creates these reliable and consistent ablation zones. And what I mean specifically is that the radiographic findings on the day of the procedure were there at every procedure. We see that area that was destroyed correspond to the zone of tumor killing, which is the same that we see every time we follow up. So when I see that patient back, it's consistently in that same area. And that was not my experience with cryoablation in the past, where occasionally the ice ball would completely cover the tumor. We felt great about it on the day of ablation, and then we'd come back and there'd be recurrences kind of right exactly where we would not expect them. And so that was, just from a urologist perspective, it was very easy to follow those patients.
Yeah. And, along those lines, my next question is going to be about recurrences. I'm curious, when you've seen them, what the strategy has been in terms of perhaps potentially repeating some sort of ablative technique, or if the patient ultimately needed surgery. Jason, I'm curious to hear if there were any technical considerations that you needed to, be aware of, given the fact that there had been a microwave ablation prior.
Yeah, so great question. And it's interesting because one of my colleagues had reached out to me years back and wanted to put together a series of patients who had had surgery after ablation. And they had primarily worked with cryotherapy. And I looked back at our series and we just didn't have very many. I would say less than 5. And we probably have 1,000 patients in our series now. It's very rare. The times we've done it, it has been definitely not as easy as a typical nephrectomy. I think the vast majority of patients that have a local recurrence, they can be salvaged with the second procedure. So we just really rarely see the need for surgery afterwards. And I think some of that is patient selection. We're not selecting tumors that probably should not be ablated. And then some of that is definitely just the technical success of the operators destroying it when it's there to be gotten the first time.
Louis, any special considerations for you if you're trying ablation for a second time?
The short answer is no. You are trying to do essentially the same procedure you did the first time, except do it a little bit better so you make sure you get all the tumor this time. The longer answer is that there is some kind of anecdotal evidence that going back to do a microwave a second time can be potentially associated with a slightly higher complication rate, likely because you've already created fibrosis and scarring that can affect both your ablation zone as well as the associated recovery. And so there are people who believe that potentially you might want to use cryoablation when you go back for a second treatment. That being said, I don't think we have enough evidence to really totally support that. That's just an anecdotal finding. And so in general, we go back, we do use microwave most of the time for our retreatments. As Jason kind of got at, we don't have very many that go back to surgery. We have a few more, obviously, that go back for a secondary treatment. And if you look at the numbers of our secondary treatments, almost all of them have good outcomes, both from a tumor outcome standpoint as well as a complication outcome. So going back is essentially the same as going back the first time. The only real challenge is sometimes it's hard to tell exactly within the ablation zone or around the ablation zone where that residual tumor is on our ultrasound imaging. So sometimes it requires a little bit more involvement of CT for our guidance and monitoring.
Got it. As we start to wrap up here, Louis, tell me, what general advice would you give healthcare professionals who might be interested in expanding their toolbox to include microwave ablation for renal tumors?
Sure. I think, most of the people who would be doing that would probably be familiar with ablation in other organs. And I think most of the concepts that you utilize for ablation in other organs, kind of transition to renal ablation as well. So the difference between treating things in other organs and treating things in the kidney is, one, there is generally a collecting system component that you have to concern yourself with, and you have to be familiar with that anatomy and how to approach it. So for example, approaching the tumor transverse to the collecting system is the preferred way with microwave, whereas you may not have that consideration with, for example, a liver ablation or something like that. So you just have to be familiar with the appropriate approaches to these tumors. The second thing is that there tend to be much closer vulnerable structures. And so the use of hydrodissection is much higher, it uses a higher rate in renal ablations as compared to other ablations. So you just have to be very familiar with those techniques and the ability to displace those tissues. The good news is because the kidney is a retroperitoneal structure, hydrodisplacement is extremely effective in this setting and essentially just requires you getting a needle within Gerota's fascia in that perirenal space. And then, the fluid is almost always able to be very effectively deployed. And so being familiar with hydrodissection is important, but again, it's much easier in the kidney than it is actually in most of the other scenarios that we utilize it. And then last but not least, I would say, people get concerned about the power of microwave and how it might be too much for a kidney. But the reality is that with modern systems, you can control your power and your time such that you can create very reliable, consistent ablation zones of a given size. And because it's a relatively short period of ablation, you have less inconsistency than you do with some of the other ablation modalities. It's very predictable. And so as a result, you can, very confidently apply an ablation knowing that the approximate ablation zone size that you're going to get. And as long as you have the tumor within that and your vulnerable structures outside of that, then you can kind of depend upon that prediction.
Got it. Now, Jason, from a urologist's perspective, if someone's interested in learning more about if their radiology colleagues do offer microablation or they're interested in having that initial conversation, what's your advice to them, particularly those who may not be in an academic setting, who may not already have strong relationships built?
Yeah, so I think my biggest bit of advice is the future of medicine is a team sport. We get the best outcomes for patients when we cooperate with each other. We have a phenomenal group of radiologists. Working with each of these radiologists has made my practice better. It has made things easier. It has made just even, outside of just the ablation, we know each other and get along and can get things done for patients in a faster way. So I would encourage urologists to reach out to the radiology colleagues, work with them closely. I think if nothing better than for better patient outcomes, but you can also build a successful program and you can do more surgery on the right people who need and who will benefit from surgery if you also offer other things like ablation and surveillance, of course, for small renal tumors.
Yeah, and congratulations to you both for building obviously such a successful collaboration, but also for setting an example, I think. We've talked a bit about teamwork throughout this episode, but it truly is the way forward as we continue to expand our toolboxes to include, these new techniques. I think it's going to continue to require tons of shared learnings and, multidisciplinary approaches to all sorts of things, including renal tumors. So, we really appreciate both of you spending some time with us to share your expertise, and thanks so much.
Thank you. It was a lot of fun.
Thank you. It was a pleasure.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for listening. See you next time.